tonight about outpatient total joint replacement surgery, which means joint replacement surgery where you do not have to stay in the hospital. We do the surgery, you do physical therapy the same morning as the surgery, and you go home the very same day. So this is a somewhat new thing in medicine in general, and pretty cutting edge, and I'm very excited that you all are here to hear about it. So we call this same day total joint replacement. So rather than requiring a hospitalization after the surgery, people are able to go home the very same day. And my plan for this talk is to talk about osteoarthritis and the basic concepts behind osteoarthritis, because that's why most people have a joint replacement surgery. And then our program with the same day total joint replacement. And this program was developed in conjunction with my partner, Dr. Burrows. And both he and I specialize in joint replacement surgery, and we're surgeons in the Bucks County Orthopedic Specialists group. So a little bit about me. I was actually born in Doylestown Hospital myself, the old hospital. And my mother was a surgeon here at Doylestown Hospital for about over 30 years doing OBGYN. And it's kind of funny because a lot of the patients who were her, a lot of the women who were her patients in their childbearing ages are now having arthritis. And it's at least several times a day people come and say they were her patient. And I did my undergraduate training at Dartmouth, Medical School, University of Pittsburgh, Duke for residency, and then joint replacement fellowship at Harvard. So what is osteoarthritis? So osteoarthritis is wear and tear arthritis. So that's arthritis of usage and aging and just basic wear and tear arthritis. It's different from other forms of arthritis like rheumatoid arthritis, which is a type of arthritis where the body actually attacks its own cartilage biologically. So that's totally different. Although they both lead to the need for replacement surgery, but the vast majority of people have osteoarthritis. So it's characterized by the loss of cartilage from the surface of the joints, and when the cartilage becomes very thin, the nerves underneath the cartilage are irritated and it's painful. So if you had a tooth and the enamel was worn down off the tooth, the nerve that's inside the tooth would get irritated by chewing and it would be painful. So it's so similar to that. So this x-ray here shows arthritis. If you see the yellow arrow, there's space between the ball of the hip and the socket, this space right here, and that's normal. And then on this side here, you see there's no space left, and it's bone rubbing against bone, and these holes are cysts in the bone. And that's very severe arthritis. So if I had to guess what the person who had this x-ray taken was going through, I would think they'd probably be in very significant pain. And then this shows what knee arthritis looks like. Here on this x-ray here, you see there's space between the bones. So that's normal on this side. And you see there's no space left here. And not only is there no space left, actually the bones are starting to shift relative to one another. So that's a particularly severe case of arthritis. And then some people maybe wonder what these things are. And those are screws. This was a female patient, and she had torn a ligament in her knee, and it was repaired at age 18, but some damage accompanied the injury, and that led to the arthritis. So this shows the MRI scan for a similar patient, and the normal appearance of an MRI scan is the bone should be dark gray like this, and all of this white area here is a bone that was injured. And so another way that people can get osteoarthritis, rather than just simply wear and tear, is if you have an injury and the cartilage is actually damaged. So if you think about like the surface of a road, and over the years the road kind of develops little cracks and starts to wear out. Another way a road could be damaged is if maybe a excavator fell off the side of a truck and it gouged into the asphalt. And so injuries are another way that people can get arthritis. Other things that really promote arthritis to get worse are carrying excess weight, smoking, or an inheritance. So if you see somebody who has arthritis and they're fairly young, like they're 50s, I always ask those patients, you know, did your mom and dad have arthritis? And almost always they said, oh yeah, my mom had 2 knee replacements, or my dad had both hips replaced. So genetics or inheritance, another reason that you see people develop arthritis. So just, I know this talks about same-day joint replacement surgery, but what options are available for the treatment of arthritis? Well, normally speaking, we start out with what's called conservative treatment, which are approaches that are non-surgical. So for people who do carry extra weight, weight loss is important, and exercise is actually very important. A very, very common question in the office is exercise worsening the arthritis? But studies show that actually being physically fit mitigates the pain of the arthritis. So as much as possible, those patients who have arthritis should keep trying to move and use their joints as much as possible. So when those don't work, some medications that are potentially beneficial are anti-inflammatories or Tylenol. And the anti-inflammatories reduce inflammation, but of course they have their own downsides. Recently, the FDA has actually put some black box warnings across the board on anti-inflammatories because they do convey additional stress on the heart and kidneys, which, I mean, it's, you know, people who are suffering in pain need some help, but for 20 years, it's maybe not the most ideal thing. And then Tylenol is another possible treatment short of surgery, although ironically there are actually some studies that show it doesn't really help, but we recommend it, and some people say it helps. Some people say it doesn't help, some people say it helps, so I don't know. So the second stage of things that can help are a little bit more active. So physical therapy absolutely helps, especially for arthritis of the knee. That's very beneficial. And then injections. So steroid injections, they reduce the inflammation, and they're almost always helpful for people. The downside to steroid injection is it doesn't reverse the arthritis. So it really it reduces the pain, but the arthritis is still there. So it's sort of like a Band-Aid approach. That being said, of course, we give many, many steroid injections to people who are trying to delay replacement surgery, and that's very appropriate. And then there are also these what are called viscosupplementation injections, and those are like lubricant injections. So our body makes natural lubricating fluid, but as we all grow older, the lubricating fluid for the joints is less cushioning, and so it's possible that to make synthetic lubricating fluid that has the exact same proteins that lubricate the joints that our natural fluid has, but in a higher concentration, and those can be injected and help pain. But they're only approved for the knee. That's not to say you couldn't do them in the hip, but the insurance, because the approval was for the knee, the insurance companies don't pay for them for the hip. So a couple times a year somebody comes and says, I'll pay for them myself and do them in the hip, but it's not super common because they're pretty expensive. So the permanent fix to eliminate arthritis is joint replacement surgery. And that's the best, really the best fix. Studies show that people who have arthritis that do not choose to undergo surgery compared to those who do, the people who don't choose to have surgery sort of deteriorate in a whole host of different medical reasons faster than those that end up having the surgery. So it's pretty common in the office that you see somebody and they say, well, I don't want to have a replacement, and you know, I just don't want to, and studies are very clearly show that those patients don't thrive and as they grow older. So this is constitutes essentially total knee replacement and total hip replacement, which is what I specialize in, both knee and hip. And this is an X-ray here depicting a hip replacement. So hip replacement has a stem that goes down the femur bone. So this is the femur bone. And then here's the pelvis, and there's a socket or the round thing here. that's placed in the socket, or placed on the pelvis. So here's a closer up picture of that, x-ray of that. So here's a socket piece, and into the socket is a plastic bushing, which we call the liner. And here is the stem that goes down the femur bone, and then a ball part of that goes onto the stem and is a separate piece. And the body biologically attaches to the stem, so the bone grows onto it, and same with the socket. And once that attachment occurs, essentially it's lifelong. And these are screws that are used to secure the socket sometimes if the person's bone is soft. So they're not always used, but if the bone's not too strong, then sometimes we put them, sometimes we don't. But they're not necessary after the attachment occurs. So this shows a knee replacement. So in a knee replacement, the end of the bone is essentially sort of recapped. So a lot of people ask me, do you like remove the whole knee? But that's really not accurate. It sort of recaps the end of the bone. So if you had a tooth again that had the enamel worn down, the dentist doesn't pull the whole tooth out. They sort of put a crown on it, which is like a replica of a tooth made of porcelain, and that is a lot like what a knee replacement is. So this shows the side view of the end of the femur bone and the top of the tibia bone, and similarly there's a plastic bushing in between. So we have a really outstanding program, I think, at Doylestown Hospital, and have a number of distinctions for our success rates, including a 5-star rating by Medicare, which is very difficult to achieve, and awarded to hospitals that have low complication rates, and as well as the Leapfrog Award for, again, extremely difficult level of distinction to achieve. So only 45 hospitals nationwide out of, I don't know how many hospitals there are, thousands, 10,000, I'm not sure, have this criteria for success rate, and Doylestown has that. Nowadays, more and more things are tracked about replacement surgery, and there's a website called Medicare Compare, where you can look at the success rates of different hospitals, and across the board, whether it's orthopedics or other things, Doylestown Hospital has exceptional scores in every measure that Medicare tests for, whether it be obstetrics or orthopedics or patients who have heart attacks, and our rates for joint replacement are definitely better than essentially all of the other hospitals in the Philadelphia region. I'm very happy to share explicitly our actual raw data of what our success rates are. So in 2010, we did about 400 joint replacements. About 20% of the people required a blood transfusion and stayed about 3 days. And 2/3 of the people went to a nursing home, and only 1/3 of the people went to directly to their house. So as time has gone on, our program has continued to dramatically improve, and the length of time people have required to remain in the hospital has continued to go down and down and down and down and down and down and down. And even though people are staying less time in the hospital, you might think that it would lead to more people needing to be readmitted for some problem that they faced, but that actually is not the case. Our readmission rate is extremely low, and as you saw in the last slide, lower than the other hospitals in the area. And incidentally, the rate of readmission is for any cause. So even if somebody had a joint replacement in January, and in April they had a gallbladder problem, that's factored in. So basically what you can see is that the average patient who has a joint replacement here at Doylestown of all ages, and I'm talking 90-year-old patients, the average patient is being able to go home on the first day after surgery. So really, what is the next step for, and fewer than 1 in 100 people need a blood transfusion. Oh, incidentally, and you also see, it's no surprise that the number of patients that have had surgery here at Doylestown has continued to go up and up, because I think people appreciate the success rates that we've been having. So basically, we've had very high quality outcomes. We've had low complication rates, much lower than hospitals in the area and among the best in the whole country. And Medicare also, I didn't include this data, but Medicare tracks the costs incurred to Medicare from patients who have surgery for replacement surgery. And Doylestown Hospital's program was the second least costly to Medicare in the entire state of Pennsylvania. And the most least costly program did 50 patients, so it's hard to know if maybe they got lucky, whereas we had over 700. And the reason the costs are low at Doylestown is because we don't have a lot of patients who have complications. It's the complications that end up having dramatically increased costs. Our choice of devices, et cetera, are like the top of the line, absolutely, that you can possibly get. So what's the next step? Well, if the average patient, including 90-year-old patients, are only requiring an overnight hospital stay, it seems very reasonable that the next step would be not even requiring a hospital stay at all. And so this is the program that we started about a year ago, and we've had excellent results with. So basically, this is because of techniques that allow for faster recovery, and people appreciate the benefits of being able to recover in their own home. And there's some people that, for various reasons, they just simply don't want to have a hospital stay when they have a joint replacement. So the patients who I view as being qualified for this program definitely have to be very motivated, and they have to be people who want not to have a hospital stay. I would never, ever, ever say to a patient who said, I'd feel more comfortable if I spent the night in the hospital, to say, no, you can't stay in the hospital. You know, if somebody feels that's better for them, I mean, I'm trying to talk more people out of not having a same-day surgery, and talking nobody into doing it that way. Only people that really want it, I think, is those who I view ought to do it this way. And we basically identify the plan for this pathway of their surgery when we decide to pursue the surgery itself. So generally speaking, when I meet a patient in the office and we decide to do a surgery, we choose a target date for surgery. And my surgery schedule usually runs about roughly a month or 2 months in the future, which is fine because it takes some time to get ready. And then we know that this person's kind of targeting the pathway where they want to go home the same day. So the way I do this is typically do these patients as the first or second one of the day, and typically use what's called a spinal anesthetic. So people are not, in a spinal anesthetic, the legs are numbed, like a woman giving birth sometimes elects to do, but people are not on a breathing machine. So you're asleep, you're sedated, you're sleeping the whole time, but you're not on a breathing machine. So there's none of that like nausea and throwing up and all that stuff. After the surgery, people spend about an hour in recovery room, and then we start physical therapy immediately. So I'm not even exaggerating. If you have surgery at 7:30 in the morning, surgery takes about 45 minutes, you're in recovery room for an hour, then you start physical therapy. Like right away, you're walking on the brand new joint. And people do the physical therapy session for a couple hours, and then they're able to go home. So how do we do this? One of the most important things, besides selecting the right patients, is the pre-surgery preparation. So all of these patients, in fact, I really recommend this for all of my patients, even if they don't do a same-day surgery, to do prehab. So instead of rehab, it's pre. It's like a play on words, prehab. And then intraoperatively, we focus a lot of attention on doing nerve blocks. So, and this is really a beneficial thing. So if you went to a rock concert and the music was blasting, and you went home in your car, what would you hear? You would hear ringing. And if you used a chainsaw for an hour, leaf blower for an hour, and it was vibrating like crazy, and you put it down, you still feel the vibrations in your hand. So if you went to a rock concert and you put earplugs in, or if you went to use a leaf blower and you wore gloves, and you never had the music being so loud in the first place, you don't have ringing in your ears when you ride home. And so what studies would show is if you were to graph somebody's pain after surgery, and the pain in the first day after surgery is so great, if you can mitigate that high spike of pain, it actually carries through with lower pain for the entirety of their recovery process. Even a week later, they have less pain compared to people who didn't do it this way. And furthermore, it allows for less use of opiate pain medication, which you definitely still need to use some traditional opiate pain medicine. It's probably unavoidable. I mean, I've had some patients completely avoid it, but it's definitely much, much less. And it's completely not it doesn't even surprise me anymore when somebody says, well, I stopped the pain medicine on the second day, because so many people say that now. Surgical techniques are very important, so we use surgical techniques where you don't cut the muscles. If you cut the muscles, you couldn't be walking an hour after surgery. I think that makes sense, right? So if you injured your leg and slipped on ice and your muscle was damaged, you wouldn't be walking on it. So we don't cut the muscles. And then with our hip replacement surgery, we use what's called a mini posterior approach. We'll talk about that in a second. And allows for full weight bearing and very low complication rate. Okay, so regarding the hip replacement, very, very, very many people ask me about anterior hip replacement, because I know anterior hip replacement is very highly advertised, especially by some local hospitals. And both myself and my partner, even though we both have done joint replacement fellowship training, a lot of people say, well, why do you do the anterior? And we both choose not to do our hip replacements anterior, and there are a number of different reasons. The people who do it advertise it, and incidentally, that's where the incision is here. The people who do it advertise it as being less invasive and faster recovery. But number one, the studies don't show that it's a faster recovery. And number two, I dispute the fact that it's less invasive. And the reason for that is that when you do the hip replacement, as I showed in that x-ray, you put a pin into the bone. And if you're lying on your side on the operating room table and you bend your hip like this, my femur bone points right to here. And so if you make an incision right here, you have a completely straight shot to put the pin down the bone. It'd be like pulling into Doylestown Hospital and the parking space right in front of the little turn-in is open. So it's just like a straight shot, no problems. But our hip, if you do an incision here, right now my femur bone points up into where my abdomen is. So how do you put something down the bone when you do incision here? Well, what you have to do is you have to bend the hip back like this. And that is not the way our hip normally moves. And in the process of doing that, it can be very difficult to do that, and complications can occur, primarily forming a crack in the bone or breaking the bone. And so as to try to do that better, what most people do and what companies sell for surgeons is sort of like a hook that goes under the bone and pulls the bone up out of the body. And you never hear that on an advertisement on Route 309 because that's not very palatable to discuss that. So you can see here, so this is an advertisement from my orthopedic journal for a company that sells a hook, and it goes under the bone and pulls the bone up out of the body. And that's not, in my opinion, very minimally invasive. I think that is very invasive. And the studies show that actually the anterior approach has a higher rate of complications. And this is a recent study from one of the most respected journals in our orthopedics. And the failure rate is much higher. So, and it's not a faster recovery. I mean, I have people every week that are an hour after surgery walking on their new hip. So I don't know how you could be any faster than that. The other reason that I don't favor the anterior approach is that there's a nerve that goes right adjacent to where the incision is made, called the lateral femoral cutaneous nerve, that provides the sensation to this patch of skin on the thigh. And there's an extremely high rate of injury to that nerve. Again, not something that you're going to see advertised on a billboard. And so multiple studies show a very, very high rate of nerve damage after the anterior approach hip. And knock on wood, I have never had a single patient in 10 years of practice have nerve damage, not even one. So to have 67% of people have, now this was initially, 67% of people have nerve dysfunction, and then only 6% of those people had it go away. That's ridiculous in my opinion. So 31% of people, these are all orthopedic studies, so I'm not just making this stuff up. So 31% of people had numbness on their thigh. At 2 years, 24% of people had problems with that nerve, and even 8 years later, still 11%. So that's why I don't favor the anterior approach. And it happens all the time. People ask me about this in the office. So it's not my recommendation. I would not want my own father or mother to have this approach. So anyway, we've had excellent success with the same-day program. 0 patients that have participated in the program have required to return to the hospital for any complication whatsoever. And the satisfaction of those patients has been extremely high. I'm very lucky that a number of those people have taken the opportunity to share their experience by those things on the internet where people write about their doctor or their hospital, and they've shared what it was like for them. And it's been a great program. It is very successful, and it's the cutting edge of orthopedics, and we're doing it safely. And oh, I almost forgot. A lot of people who, this should not be the deciding factor, but there are a lot of people who have insurance plans where a surgery done with a hospital stay is substantially more expensive than a surgery that's done on an outpatient basis. Particularly with those plans like the Obamacare plans where people pay the first $6,000. A lot of those plans, if you had an outpatient surgery, they just charge a flat fee and it might be $200. But if you had a stay in the hospital surgery, it's for many people much more expensive. So I guess that's it. So we have lots of time for questions. Yes?
You were talking about the same day go home. Is that for knee replacement? Is that one knee or both?
Only ever one knee.
Okay.
And at the present time, Medicare, traditional Medicare, allows it for knees but not hips. And any other insurance could be hips or knees. I anticipate, because it's been so successful for knees for Medicare and been so dramatically reducing the expenses to our country, that I would bet $100 that in 2019 Medicare will do it for hips. If anything, hip patients are easier to go home the same day.
But this program is only for one knee
Correct.
replacement.
Not for a double.
If you have a double, how long is the hospital stay?
Excellent question. So for patients that have a double, I would say about 2/3 of the patients stay 2 days in the hospital, and 1/3 of the patients spend a few days at a place called Moss Rehab, which is on the first floor of the hospital, and it's 6 beds, and they do about a week of accelerated rehabilitation. And both are very effective. My father had a heart valve repair surgery and went to Moss Rehab, and they were wonderful. They're very nice. Yes?
I feel like there's more and more surgeries that are outpatient. Is that, and I don't mean this to be insulting in any way, but is that driven by insurance, or is it the best for the patient?
So that's a really good question. So it is definitely driven by insurance. Aetna patients who are in the private Aetna, not like Aetna Medicare, if you're having a single knee replacement, Aetna says they're only covering it on a go home the same day basis, unless you have some medical condition that is on a list of things that require you to stay. Now, if somebody said to me, I live alone, I have Aetna, I'm 63 years old, I live alone, the person's kind of frail or something like that, probably what I would do is I would really, when I make their notes in the office, I would really play up any kind of medical condition that I could try to do to get their surgery covered on an inpatient basis if they didn't think it was going to be safe. And again, we're not, as doctors, we're not trying to push patients to do the go home the same day, only those who really want it. Because I don't want, the number one thing you don't want as a doctor is you don't want complications.
Sure. As a patient, same thing.
Right. Yes.
On your phase one where you're talking about exercise, and I understand the exercise being good for conditioning the muscles around the joint, but doesn't the exercise work with the wear and tear?
While that is true, the benefits of the strength in the joints outweigh the...
Holds it up.
Correct. Right. So if you had a classic car, and you said, well, I have this beautiful old Corvette from 1958. If you never started the engine, you never drove it, you said, I'm not even going to put 5 miles on it, it actually is more detrimental than if you used it from time to time, just in a respectful way. Yes?
How far ahead of the surgery should you start the prehab program? And the same kind of question, what should I expect for rehab after the surgery?
Oh, okay, so good question. So, it works out pretty well. So my surgery schedule usually runs about a month to 2 months in the future. So when people elect to do the surgery, I say, okay, well, let's do your family doctor visit to do a clearance, and we'll do pre-surgery prehab. And typically what that consists of is an assessment visit and maybe 1 or 2, 3 visits on a weekly interval to get some exercises to do. So it's not, because Medicare, for example, only allows a certain number of visits, and you don't want to burn through all your visits before surgery. So like 2, 3 visits, you do your own exercises. Now, what about the after surgery? So when people do the go home the same day program, what we typically do is we have a nurse meet them at home, so that when they arrive home, the person's there and they do a session of physical therapy at home. So that would be their second session for the day. And then again the next day. And then on the next day after surgery, they go to a therapist's office. When people do the surgery where they stay in the hospital, as you saw from those charts, the vast majority of people go home the first day after surgery, and they do surgery in the hospital that morning. And then the next day go directly to a physical therapist's office. And in your point too, another thing that is a new trend is there's some joint replacement programs that are not even recommending therapy at all. So what they're doing is they're giving people, like, go to a website and it's going to say straighten your leg 5 times, and we have not signed off on that approach. I'm not sure that that's necessarily to the betterment of the patients. So yes.
Speaking about physical therapy, once you go home and you've done your 2 or 3, and then you go to the office, how long are you going to be going to the office for physical therapy?
Oh, good question. So, how long do you go to a physical therapist's office in total? So usually about 6 weeks. I usually let most people drive in about 2 weeks. You can start showering and day of surgery is fine.
How many times a week?
2 or 3 times a week. But the average patient that comes a few weeks after surgery, whether it be hip or knee, is I brought my cane because it was raining today. They go to the grocery. They're already going to the grocery store. It's amazing how far things have come. Yes.
What is the term Superpath?
Okay, Superpath for hips.
Yes.
Okay, so Superpath is a style of hip replacement that rather than an incision in the front or an incision in the back, the incision is made on the side like this, and the hip, the approach to the hip is sort of from the top, but it is hardly anybody does that way, because the cup part of the hip, which you saw in those x-rays, points down this way. So if you make the incision up here and you have to put something that points this way and you sort of hammer it in, it's very cumbersome. So there's a surgeon in Massachusetts who does this, and I don't know of anyone in Philadelphia that does it. And I don't know that the results have been that publicized. Yes?
A patient with osteoporosis, now assuming you're doing a knee replacement, is it dangerous to drive that spike down the femur if the patient has osteoporosis?
No. The technique that I use, I don't actually, although the x-ray depicted a knee replacement with a spike, I don't use one myself, but even if you did, it's not a problem. Yes?
Thank you.
Would this take a surgery or stitches required or what?
So typically, my personal habit is that I use Meltaway stitches with glue for the skin. My partner uses Meltaway stitches with staples for the skin, and both have completely equivalent results. It's just a matter of personal preference.
Can you just go back to the office to have them?
Well, those who have staples, either somebody, office, the way I do it, they don't have anything to remove, so. Yes?
A knee replacement, how long is the scar?
Well, it really depends on how the person's frame. A lot. It depends a lot on the size of the person's frame. I mean, those patients who are very skinny legs, it's smaller, maybe about this big. And the people, if they have a bigger frame, it's bigger.
And it's over the knee?
Yes, always pretty much in front.
Below.
Yes. Yes.
What's the limitation on sports that you have?
Oh, that's an excellent question. So every year I enjoy going to the meeting for joint replacement surgeons in Dallas, Texas. And one of the funnest parts of the weekend meeting is when and this is a absolutely gigantic meeting. There are probably 2,000 people that attend this meeting. And, like 100 times bigger than this room. And they put out these little like television remote control things, and they do a survey of people's practice habits. And it's a lot of fun. You get to see what year by year, what people are doing, what blood thinner people use for blood clot prevention, and so on and so forth. And one of the questions they ask every year is whether surgeons recommend contact sports after replacement. And it's typically about 50-50. No study has ever actually assessed whether it's okay. So there's no medical literature to guide that decision. It's 100% professional opinion. And out of like practically every joint surgeon in the country goes to this meeting, and it's 50-50. So I typically tell my patients that, if you go to a family picnic and you're playing softball, that's totally fine. Do I recommend like marathon running? No.
What about snowboarding?
I think that would be okay. Yeah. Yes?
Do all the surgeons in your practice do the same day?
Myself and Dr. Burrows do the same days primarily. Yes?
From what I'm hearing, it seems that the need for same-day surgery evolved from the insurance industry and also from patients.
No, it definitely is from patients. So this thing with Aetna happened after we started this.
Didn't necessarily recommend this over a traditional.
No, I think it's great. The overall program at Doylestown Hospital has an exceptional track record. However, and I come from a family of doctors, but it's just simply a fact that being in the hospital can sometimes lead to adverse outcomes occurring. And so if it's safe to do so, not having a hospital stay, I think is awesome.
I have another question about return to work. Lengths of time after a knee replacement.
Okay, so that's a good question. So what I would typically say if somebody, I get this question a lot, so the way I usually put it is, if somebody were a school teacher, if somebody were an accountant and they were working at a desk, I would say 2 weeks. If they were a school teacher and they were standing but not doing much like super physical, I hope there are no school teachers here, so maybe they would say that is physical. At times, depends on how old they are. I would say a month. A nurse that has to move a patient, I would say about 6 weeks. A construction worker, I would say 2 months. So somebody on a ladder, I would say 2 months.
About golf,
Oh, golf,
same day?
you know, pretty quick. I think maybe just a couple weeks.
What can you expect as the downside?
Well, okay, that's also a great question. So, for some reason, it never comes up in the office. So for about a year, people have a diminished sensation next to their incision, but people ask about it, but I've never heard somebody be bothered by it, you might say. I like to see patients have full straightening all the way, and bending at least as good as what they had with their arthritis. It's a knee replacement knee compared to your knee when you were 40 years old is typically slightly more swollen than the other knee. So not noticeably, I mean maybe just like a little bit. So sometimes people come and they say, is it gonna ever be quite as slender as my other knee was? And I would say maybe, but not assuredly so. But that's not really that big of a deal. And I would say that it's very common, very, very common. I hear people come because I like to follow my patients like pretty much forever after the surgery, that people say, well, I went through the airport and the machine, the metal detector beeped and I took off my watch and I went and it beeped and I took off my belt and it beeped and I took out my keys and then they said, oh, did you have a replacement? And they said, oh yeah, I forgot. So I consider successful joint replacement to be one where by about a year after surgery, people don't even think about it.
What about diagonal?
That should be okay. Yes?
On that hip replacement, the size of the incision was?
Again, very much dependent on the size of the person's frame, probably even more so than the knee, because people have more of a discrepancy of how much weight they carry around the hip than the knee. But you know, in general, I would say about this much. But it really does not correlate with how fast you recover or how much pain you have.
I ride horses, so I was curious if I'm going to be able to do that again.
Yeah, that would be very reasonable. Yes?
Is there any data like you showed us on the day surgery versus staying in the hospital?
The only data I can quote is that among the patients who have gone home the same day, we have not had any major or minor complications or hospital readmissions. Now, those patients have been healthier patients, so it wouldn't be entirely fair to compare them to, you know, older patients or something like that.
But maybe the ones overnight ones might be worse.
No, the people. One of the things that relates to possible complications are people's comorbidities. So if somebody had heart disease or something like that, and so since we would not promote a go home the same day approach to somebody who had a lot of comorbidities, the fact that our go home the same day patients have had 0 complications over about a year of doing surgery, while is wonderful, is not entirely fair because they're like very healthy people. But I think what it shows is that you don't put yourself at risk by doing it this way if you're properly selected for it. Does that make sense? Yes?
You can drive in 2 weeks if it's the right thing.
I mean, as long as people aren't taking narcotic pain medication, and I don't typically let patients with like a commercial driver's license, like a school bus driver, do that. But I would say pretty much that's, you know, I suggest to most people practice in their neighborhood first, and I don't know if you're first.
The incision, is that on the, where's the incision?
Right in front.
Right.
I think a good deal of people do it anyway. So, now I don't know if it's the best thing to do to, you know, go drive on Route 309 at 7:35 in the morning in the rain on your very first time out, but I think, you know, it's okay.
Now, do you do the spinal for the hip too?
Uh-huh.
Okay, anybody well over 90?
Oh, yeah. Yeah.
Is there healthy enough?
Yeah. No, spinal is awesome. Spinal conclusively has lower complication rates than general anesthesia.
And less hard on the heart and what have you?
Absolutely. That data is clear cut. Yes?
Talk to me about pain, level of pain, like you go home the same day. What's my pain level? 10?
So the hip replacement does need, okay, well, in case somebody is thinking about hip replacement, the hip replacements don't have really bad pain, typically. Knee replacements could potentially have really bad pain. However, what we do across the board here at Doylestown is people get a nerve block that numbs the pain, and it lasts for about a day. And so typically the pain you would have felt for the first day is substantially mitigated by that nerve block, and you would have been essentially going home at that time anyway had you stayed in the hospital anyway. So you know, it's people say it's pretty sore, but tolerable. I mean, you know, 1 million people, more than 1 million people a year have replacements. Yes?
Just ask my question. Tell me a little bit about like the hip precautions.
Okay, so that's a good question.
Yeah, I know you can't bend over.
So one of the things is that you don't want to inadvertently pop the hip out of socket.
No.
So we don't have people cross their legs or bend all the way to the floor. So we suggest people limit their bending to 90 degrees, and particularly bending and twisting.
For how long?
For about 6 weeks, but the dislocation is pretty rare, and the people who dislocate, they typically dislocated because they did something really dumb.
Like a trampoline?
Well, no. I mean, when I think about people who dislocated that I've taken care of, I think about a person who's driving their car to Florida, her husband's driving and climbs from the front seat to the back seat, stuff like that. So typically people who have or fell downstairs or something like that. Typically people who have or alcohol. Alcohol is a big common factor among people who dislocated. So what you find sometimes is that you didn't pick up on it in the office, but maybe people drink a little too much and they go home and they are 2 weeks after surgery and they didn't drink because they didn't think it was a good idea, and then they kind of get the urge to drink, and they have, you know, like 2 gigantic glasses of scotch, and they their body is not, your muscles are not working the same way, and then they end up dislocating. But it's fairly rare.
How long do the replacements last?
That is a really good question. In most patients, I would expect them to last their whole life. So that, they only last 10 years, that's sort of very passé. So I would say, I would expect it among my entire career, I would expect at least 90% of people to have their replacement their entire life and never have a second surgery.
Are you talking about hip or?
Both.
Both?
Mm-hmm.
So there's no benefit to waiting?
Studies show that those, well, within reason, I mean, today I did a replacement surgery on somebody who's 44. Now that person, he might have 50 years of life. However, he had done everything short of replacement surgery. And he's a cabinet maker, and he has to provide for his family, and he absolutely had no choice. And I hope in his case it also lasts his completely entire life, but for the more regular kind of replacement surgery patient in their 60s-ish, studies fairly conclusively show that those patients who sort of delay, they actually never catch up to those patients who did it sooner. Does that make sense?
My sister had one replaced when she was in her early 40s.
I had 2 patients in the 40s this week, 143, 144.
Yeah.
You think it might actually last 50 years?
I am very confident that patients with a hip replacements will last 50 years, for sure. The knee, given the fact that man's a laborer, and if you jump off the back of a pickup truck, land on your knee, that adds wear and tear. But my hope would be, yeah.
Wow.
At what point did things go from lasting 10 years to lasting life?
Okay, so this is very interesting. The plastic that's used as the bushing material is polyethylene, which is the same plastic that's in milk bottles, like a gallon of milk. And everything that's implanted in the human body is sterilized by being irradiated. So whatever the product is, whether it's a cataract or a stent for your heart, it's cleaned and washed, and then it's put into packaging. The packaging is sealed, and it goes under a machine to irradiate it. So it's sterilized in the package. So even if hypothetically the person who packaged it had a hair fall into it, it wouldn't really matter because it would still be sterilized. And it was identified sort of serendipitously that the bushings that had a longer sterilization period had a longer longevity. And it was identified that the polyethylene, which is a long molecule, the radiation causes the long molecules of polyethylene to interconnect, and it's called cross-linking. And it was patented around 2002-ish. No, maybe more like 2008, sorry. It was patented, that cross-linking process. And it was patented by 5 guys. And they actually, they're all from Boston. And that's where Bill Harris, Harry Rubash, a scientist at MIT, and some other guys. And that cross-linking process, now done intentionally, not just for sterilization, cut the wear rate of the plastic bushing by a factor of about 100. So there's practically undetectable wear in the plastic bushing. And since the other components are more or less biologically bonded to the bone, the part that would wear out would be the plastic bushing. And since that doesn't essentially wear, so in robot simulators that run for a simulated 10 years of usage, you take the plastic bushing out and measure it with the most accurate micrometer, and there's 0 detectable wear. It's ridiculous.
Do that in
Yes?
How many surgeries are going on at once when you're doing surgery?
So there are no student doctors. So I do the entire surgery start to finish. So I do 2 operating rooms, and I do 1 surgery, finish, and then do the other surgery while they're cleaning the OR. But there's no overlap or ghost surgery or student doctor or anything like that.
So you're doing one and then that's finished before you do the other?
Correct.
Or going back and forth?
Well, I am going back and forth, but they're finished, and then I go to the other one, and finished while they clean it. And the amount of time it takes to clean the operating room is essentially roughly equivalent to the entire time it takes me to do the other surgery. Does that make sense? So there's at other hospitals where they have student doctors, you know, and the student doctors starting the surgery and doing stuff. We don't have, that doesn't even exist at Doylestown Hospital. The only person who does the surgery is your surgeon. Whether
You're doing part of it and then you have...
No, whole thing from the beginning to the end, just your surgeon.
But are you going to the other?
No.
No. So what is the cleaning up afterwards?
Well, the OR has all the stuff and all the instruments, and they have to, you know, mop the floor and bring out all the old instruments and stuff like that.
Before you move on with that surgery? Or
No, that's when it's finished.
It's when it's finished. So you're just like in one room all the time with that person and then you...
Yes,
do it.
exactly.
Okay.
So that's in contrast to, you know, and everyone has to learn. I learned myself, and so there are teaching hospitals where students learn, and the student starts the surgery, and the doctor comes when the student's kind of midway through to make sure everything's going okay. But that's not what we have at Doylestown. It's only, there are no student doctors, so the only person that does your surgery is, if I drop dead in the middle of surgery, you're in trouble. Yes?
How many years have you been doing
This is my 10th year. And Burroughs is what, 20 years? Yes?
What about stairs after you did the operations?
Typically the same day. So, okay, maybe this is our last question. This is a whole hour.
Okay.
Yes?
I just have two opposite things, but I'm going to maximize the time with you. The first is with regards to insurance and what they have forward. Do they require that you exhaust other
Yes.
one options before they will?
Essentially every insurance plan, including Medicare, now has a set of kind of criteria that you need to demonstrate to them that the person has tried non-surgical treatment. So and you need to explicitly lay that out there when the request to perform the surgery is made to the insurance company. And it's sort of like a menu, so some things might not be appropriate, like if somebody has diabetes, you definitely can do cortisone shots, but if somebody had bad diabetes, you might not be your first choice. So it's okay that you didn't do a cortisone shot in some patients, but then you must have tried other things, which is appropriate because we're not the kind of place that's going to tell somebody have surgery because you haven't tried anything. That's no good. You don't want to go to a doctor that's going to say, oh, you have pain, have surgery. We definitely want to try non-surgical things first. Well, if you saw the criteria, it says, well, a person has, it's sort of like a menu. So Aetna, Blue Shield, Medicare, they each have their own thing. The one, for example, for Medicare says, have you tried medication? It could be Tylenol, anti-inflammatories, or does the person have a contraindication to medication? So if the person had 5 stents in their heart, I wouldn't want to use anti-inflammatories. And so, that's okay. So that's the one thing. And then the next thing was, their level of impairment. Has the person had pain for greater than 3 months? Well, I would never schedule somebody for surgery. Didn't have pain for more than 3 months, so okay, check, yes, they have that. And then the third would be, have they, for those patients who are overweight, have they attempted a weight loss program or something like that? So I think that philosophically, is it great that kind of bureaucrats are getting in the middle of decision making? Maybe that's not so desirable. However, I don't think that the criteria are that onerous because I think a reputable doctor probably wouldn't offer somebody surgery that didn't meet those criteria anyway. Thank you all for coming.
Doing my surgery on the 29th of August.
Thank you.